A toe turns black, a wound appears, a patient arrives in the emergency room. The question isn't how did this happen, but it actually becomes a better question when who was watching this before it happened. So because the diabetic ulcer is rarely just a wound, it's never just a wound, right? It's a warning signal. It's a visible sign of an invisible disease, the neuropathy, the vascular compromise, the infection, the inflammation, and sometimes where the healthcare system has failed, okay, to connect the dots for that patient. So, welcome back to Diabetic Foot Files. I'm Dr. T, and today we're going to ask a simple question, but it's actually quite complex and more complicated than it seems. Who owns the toe? So, first, the toe belongs to the patient, yes, right? But who protects it? The toe is not just an anatomy. It represents independence, mobility, employment, quality of life, and identity for the patient. And for a person with diabetes, losing a toe can start a cascade. I remember saying a few episodes back, I had a patient who was just randomly reached out to me about trying to save his toe. He did, but he was telling me that the last doctor told him once you lose a toe, the others will follow. And I thought that was very pessimistic of the doctor to explain. Yes, the risk is very high after losing one toe. There's transfer lesions, the biomechanics change. It does show what's going on, that the diabetes is trying to take over the body. Not a lot of things, but it's not a need to be that pessimistic, but tell them that they're at higher risk. But it does start a cascade. Losing a toe starts a cascade. You have altered walking mechanics, okay? The biomechanics of your body does change. There's increased pressures elsewhere, like I said, transfer lesions. There are recurrent ulcerations. There are increased infections and further amputation risk. But the toe itself does not just wake up in the morning and says, I want to fail. It's actually a pathway, a progression, a story. So, at what point did the healthcare system recognize that this toe was in danger? Now, the foundation is the patient has an autonomy, okay? That's something that we have to respect. The important principle of patient autonomy. In modern medical ethics, a competent adult has the right to accept treatment, refuse treatment, make decisions about their own body, and receive the information necessary to make the right decisions for themselves. This comes from a broader legal concept of bodily integrity. But your body is not just considered the property of your doctor or your hospital. A surgeon does not own a body part because they remove it, right? The procedure is performed under your consent, the patient's consent, and the patient grants permission for the intervention, such as the amputation. But the first owner is we gotta think about prevention. So before a wound exists, ownership begins. The first person responsible for protecting a diabetic foot may be the patient primary care provider, the diabetic specialist, the podiatrist, or the patient. And a diabetic foot exam isn't just looking at the skin. It's about asking, is there neuropathy present? Does this patient feel pain? Do they feel, is their protective sensation intact or is it fully diminished? Circulation. Can blood flow reach the tissue or do they have vascular compromise? The biomechanics. Where is pressure damaging the foot? Is there a callus forming? Okay. Is there an area of increased pressure? Footwear. Are we creating injury every day with wearing the wrong footwear? Education. Does this patient know the warning signs for a possible diabetic foot ulcer or amputation, progression, things like that. Because, like I said, when you have a patient that has neuropathy and they start feeling a lot of pain and they have neuropathy, that's a really big sign. That's a big warning sign for that. That something is definitely wrong. So let's say when the toe enters the healthcare system. So now let's say the patient develops a blister or a callus or a crack or even ulcer, drainage, redness, right? The clock starts ticking. So the diabetic foot is in a race against the infection, the ischemia, and the tissue death. But here's where the problem begins. The patient you know, may see their primary care doctor and they'll be like, okay, we're going to refer you to wound care, right? And then patients in wound care, then they get referred to vascular. And vascular says they need to refer them to infectious management, okay? And then infectious disease say you need source control, and then they get surgery. Surgery says it might be too advanced, you might need amputation, okay? So everybody's touched the case, but from my experience, it's a lot of referral time, getting that coverage when patients have insurance or getting an appointment at the appropriate time, you know? Did anybody else own the outcome of it? Because we have to remember these patients have to follow up. They have to find somebody who's under their insurance, okay, if they have insurance, and they have to have a appointment time, you know? And most of the time, when it comes to the diabetic foot infection, they don't wait. The diabetic foot infection doesn't stop the clock and say, hey, we're not going to progress this infection to continue until you finally follow up with vascular or you finally follow up infectious disease. No. So the problem with a diabetic foot ulcer becomes a shared responsibility. So healthcare is built around specialties, and that is necessary, but sometimes shared responsibility becomes a fragmented responsibility. So a diabetic patient may have a podiatrist that's managing the wound, a vascular surgeon who's managing the flow, infectious disease that's managing the antibiotics, endocrinology that's managing the diabetes and glucose, and nursing manages the dressing, right? But who's asking what is the entire limb trajectory, okay? So who's watching? Is the wound shrinking? Is perfusion improving? Is the patient infection getting controlled, like the actual source control? Is the patient getting closer to healing? So who owns the toe, right? So primary care owns when it comes to the beginning of it. So the screening, the risk stratification, risk identification, the diabetes management, the referrals. I don't know who came up with the referrals thing because it plays such a huge role with the patient getting to a specialist and the insurance either approving or saying, oh, you need this paperwork to refer and get approved to see this physician. And a lot of patients, their doctors are booked out, especially if it's a new patient. They might not be booked out until like months until they see a new patient, right? So that is a very big problem that we have to rectify for our patients because these patients, these diabetic patients, they deserve, I believe, priority, in my opinion, because diabetes does not wait. It does not wait. Okay. Podiatry, we own the foot and ankle depending on the state, right? Prevention, pressure management, wound evaluation, biomechanics, limb preservation. Vascular, they own the highway. The blood flow, the revascularization, the ischemia, infectious disease, they help with the enemy, the complicated infections, the antibiotic strategy, especially when it comes to kidney clearance, things like that. And surgery, the battlefield, like where we need debridement, possible reconstruction, amputation decision, and nursing with the daily dressing changes, the wound monitoring, the helping with the education and adherence, right? But who owns the actual patient's journey? So when an amputation happens, who owns that? So we need to have an honest conversation about that because not every amputation is a failure. Absolutely not. Sometimes amputations are actually life saving. That's what people need to understand. Okay, because sometimes if the amputation is needed to be done, is to help save the patient's actual life, and sometimes the best outcome is removing a non-functional infected limb segment of that. Okay, but the conversation cannot begin in the operating room. The conversation must begin months earlier. We need to ask, was this patient screened? Was their circulation assessed? Was pressure relieved? Was infection caught early? Was there access to actual limb salvage intervention? Now, from a patient's perspective, imagine a patient and you hear the patient hears your toe needs to come off, but your questions aren't like, why? Or could this have been prevented? Who knew that this was happening? What could have been done differently? Did the patient or did anybody see this coming? And patients don't just lose their toes, they actually lose trust in the healthcare system when this happens, right? And what happens when the toe is removed? So when amputation occurs, the hospital generally treats the removed tissue as a human specimen, and that's for several reasons. First, for medical evaluation, the tissue may be needed, well, definitely will be needed for pathology examination, diagnosis confirmation, evaluation for the infection, cancer assessment sometimes, and documentation. For example, a diabetic toe removed for suspected osteomyelitis might be actual confirmed osteomyelitis, right? May be examined to determine is there bone infection, are the margins clear, is there unexpected pathology, Another reason is for infection control. Hospitals have the obligation to safely handle biological materials properly, prevent exposure risk, follow public health regulations. A hospital cannot simply hand every amputated part back immediately without considering the safety and the policies. And we'll go into that. Now, can a patient keep their amputated toe? That's a good question, right? Because we actually get asked that question. You'd be surprised that I have been asked that question. Okay, but sometimes you can. Okay, sometimes you cannot, but it's not automatic. Okay, policies in hospitals do vary the state and circumstances, and a patient may request, "Oh, can I have my amputated toe back or their limb?" I'm sure people have seen. There's this trend with the rib removal and people show their ribs and oh my gosh, one thing in the social media they've been like boiling their ribs to show. I don't know why they're doing it, but they've been doing the rib removal so that their waist can get smaller and they'll show a picture of their rib that they got back from their surgery, right? However, hospitals have requirements such as pathology examinations first, release paperwork, infection precautions, and approval from pathology and risk management. So some hospitals may be allowed to return an amputated part, like an amputated toe, after required testing, but others may prohibit it, the release of that part because of biohazard concerns, regulatory requirements, and institutional policies. So the property question. So legally, human tissue occupies a strange category. It's not treated like a car or jewelry or personal belongings. And you cannot usually say, the toe is my property, therefore I demand immediate possession of my toe. So human tissue law is complicated because society recognizes as dignity, respect for remains, public safety, as well as medical research needs. So the tension between the patient's relationship to the body and versus the institution's responsibility of that human specimen after removal. So the future, giving the toe an owner. So the future of diabetic limb salvage and diabetic limb care, okay, may require creating systems for every high risk foot to have some type of surveillance. Like we said, the future is like smart insoles, temperature monitoring, like podiatrics, artificial intelligence, remote wound monitoring, and predictive analytics. So the goal is not to wait till the toe is dying. Finally, you know, not till the moment before you need actual amputation. It's never like that. Okay, it's always a progress before that. So, who owns the toe? The answer is always going to be complicated. The toe belongs to the patient, but protecting that toe belongs to everybody in the healthcare system. Okay, so the future of diabetic foot care isn't just better treatment after wounds happen. It's creating a system where no patient foot becomes invisible. We don't want the foot to become invisible. Okay, because every toe has a story, every wound has a timeline, and every limb deserves somebody to watch it to make sure that that limb gets to be preserved, okay, and salvaged. And that's why the whole point of the healthcare system is for us to help increase the quality and care of patients' lives and their feet and keep you still walking and standing. So this has been Diabetics with Files. I'm Dr. G. I hope everybody had a great Sunday and take care of your feet because they take care of you.